Hi guys, Dr. Douglas Gillard. Welcome to another video. Now this one's going to be a little bit different. The impetus of this video is secondary to the fact I get about maybe 7 to 10 emails a week, and they all have the same theme. They all will attach 3 or 4 JPEG images of their MRI or CT, and then they'll say, Doc, I hurt my back 8 months ago, and what's the matter with me? I've attached my MRI images, and then what kind of treatment? Do I need surgery? And I mean, they're well-intentioned people, and I feel for them, but it's absolutely ridiculous to expect me to give you an answer about the cause of your back pain based on that type of data. I mean, there's just not enough information there. Even if I had your entire MRI images, all your MRI images on a disc, and I didn't know anything about you, I still wouldn't be able to offer a very good explanation or pick out pain generators. It's much more complicated than that. It takes years and years and years of not only schooling, but also clinical practice before you get good at figuring out what's the matter with somebody. And so I thought, you know what, I'll make an educational video and let's teach the public a little bit about what goes into it. All right, and make sure you read my warning. I'm certainly not trying to teach you to make diagnoses, but I just want you to appreciate how hard it is. All right, and then before I start, a little plug for my coaching, and this is how I answer those people's emails. I'm sorry about your pain, but I have no clue what's the matter with you. I need much more information, but I'd be happy to talk with you via a GoToMeeting coaching session. And basically what they do is upload their MRI images, a little history if they have it. They fill out my pre-coaching session questions. There's my history. And then they go over to that YouTube video I just made, and they do some simple muscle testing, which they can do. And then I have enough information to make a really good educated guess about the cause of their pain, and more importantly, what is the medical or the evidence-based treatment options for that pain. All right, so let's get going into this video. I hope you enjoy it. I'll talk to you a little bit at the end. All right, here we go. The title of this presentation is Figuring Out What's Causing Your Back Pain. How the heck do you make a diagnosis? And we can tell you right now, it's not as easy as you think. Now, here's a classic example of the email I got the other day from Jennifer. And I do have her permission, by the way, to use this as long as I blocked out her name and stuff. Told her I was making a video on this. She was very kind about it. So this is classic. I get a video, and hi, Dr. Gillard. I've attached 2 pictures for my latest, I think it should be from my latest MRI. Could you please tell me why I have this terrible back pain? Okay, so that's all I get. So that's... It's not that easy, right? If it were only that easy, you wouldn't need my service. All right, so figuring out the possible causes of back and leg pain, it's not easy, as we said. Because why? Well, why isn't it easy? It seems easy. Because there's a lot of things that can cause back pain. It's not just a sprain strain. You just pull a muscle. I mean, sometimes it is, but it doesn't always have to be, and that's the danger with not making a good solid diagnosis. Look at all these things that could cause back pain. Okay, muscle sprain, strain, no big deal. Annular tear in the disc, probably the most common cause of chronic low back pain. Disc herniation, right? Spinal stenosis, scoliosis. I have information on all of these, right? Go to chirogeek.com and you can learn about all these things. Spondylo. Facet and SI joint syndromes also can cause back and some leg pain. But now we got a fracture, we got infection, we got neurological conditions can do it. Rheumatological conditions, ankylosing spondylitis comes to mind, rheumatoid arthritis. There's other things that can do it. Spinal cord tumors, bone tumors, cancer. Then you can get something called referred pain, where the back isn't hurting at all, but it's getting pain referred to it. It's like when someone gets a heart attack. Where do they get the pain? We've all seen the movies. They get pain down their left arm, and really they can get pain in their jaw or in their middle back. The heart attack has nothing to do with their left arm, but that's called the referred pain, right? So kidney stones, kidney problems, tumors in the uterus, all sorts of things can refer pain. to the back. Abdominal aortic aneurysms can refer pain there. And then you can have psychological conditions can also make pain appear when there's no cause for it except psychological problems. So now you get an idea of why the heck it's not easy to make a diagnosis, right? Another problem is false positives with medical testing. Okay, that's a big problem. For example, we know that 30% of people, approximately 30% of people who have never had back pain in their lives, if you just grab them off the street and put them in an MRI tube and take an MRI, they'll have a small disc protrusion, yet they've never had pain. That's an example of poor specificity or a false positive. All right, here's a chart from my legacy research page for all of those of you who've been asking over the years, where's that old research page? I finally put it back up, so it's at this link right here. But yeah, these are the studies where that 30% comes to. Famous Jensen study published in the New England Journal of Medicine, Bowden, Boos, all these. Boos I actually took out. This is an interesting one. They didn't look at normal population. They looked only at high-risk populations. So they took construction workers, people are exposed especially to vibration, like truck drivers, or another group here. And then they did MRI. The patients never had back pain, but they did MRIs anyway. 63% of them had protrusions without any pain at all. So you got to be careful. You can't just look at an MRI and say, "Oh, that's the cause of the sciatica or in the patient's pain." 13% even had a disc extrusion, which is herniation bigger than 7-8 millimeters that broke the posterior longitudinal ligament. So you get my point here. And it's a long road. So in order to figure out which one of these things is causing your pain, it takes years and years and years. In school, we had to study each one of these things. Every one of these had lectures on them, and some more lectures. And then in clinical practice, we learned about, oh yeah, this guy's, he didn't have a disc herniation. He had a degenerative spondyle that slipped. Intensive study on all these things, right? Your run-of-the-mill chiropractor, most of them these days have BS degrees, and so that's 4 years. And then they have another 4 or 3 or 4 years, depending how fast they go. But so you're looking at 7-8 years of advanced education in order to figure out and why, in order to make a diagnosis. Healthcare professionals can make a diagnosis. Orthopedists, physiatrists, 10 to 12 years. Spine surgeons, sometimes 14 years if they've done fellowships. So lots of education. Now do you understand why I just can't answer your question? No, you still don't understand. Okay, let me go into it a little deeper, because let's really get into how the heck to make a diagnosis now. What is a diagnosis, first of all? It's a medical term made by primary healthcare providers, by doctors. Only doctors, licensed doctors for that matter, can make a diagnosis. And what is it? It is basically the cause of the patient's pain. There's several, I'm not going to get in some of my classes, I get into these, but there's a working diagnosis where really we're always having a working diagnosis. I mean, diagnosis is, why is it working? Because you're ordering new tests. You're learning more about the patient. You're getting more information coming in. So it's constantly changing. That's called a working diagnosis. The only time you have a final diagnosis is when you're 100% sure, like a fractured forearm. That's a primary diagnosis. It's not working anymore because, well, maybe it's still working. Maybe they have chronic pain after that. So this is the one you're working while you're treating the patient. Sometimes patients in a car crash, they have neck and back pain. So you can have a primary diagnosis, which that's the primary complaint, the one that's most concerning. And then a secondary diagnosis, the patient has this, but it's not the primary focus. Yeah, and again, it can take decades and decades for doctors to get really good at making an accurate diagnosis. So let's get a little more specific. What do doctors use to make a diagnosis? Well, they use data. They use data to make it, not data, data, like on Star Trek data. So you got to collect data. What type of data do you need? Now this is kind of how I used to teach this. The three-legged stool is the bare bones diagnosis. So you need 3 data sets in order to make a foundation for a diagnosis at the bare minimum. So let's talk about these 3 legs. So in other words, you need to collect imaging on the patient. We're talking more about like a chronic back pain patient. You need to have a history to figure out what's going on. I wonder if you can actually, sorry about that. I hope you could see my pointer there. And then importantly, you need examination findings. So these are all 3 data sets that you need to build the stool, the diagnosis stool, I call this. So it's a 3-legged stool. If you have all 3 of these data sets, you have a pretty sturdy foundation and you can make a pretty good diagnosis. Okay. What happens if one leg of the stool is missing? Well, the stool falls over. It's not very accurate if you don't have all 3 of these categories. That's why in my coaching, I make sure I get a history. I get the imaging, and then we do some examination. I get it either from someone else's report, and I always have the patient do muscle testing, so I can make a pretty good guess at what's going on with the patient. Okay, pretty good with that. So really, you want me to make a diagnosis with less than? So this is just the emails. This is an example of someone who says, hey, here's a couple of my imaging pictures. What's my diagnosis? I have no history. I have no examination findings. Really, this is like half a leg because I've had low back pain for the last 8 months. That's not a history either. So it's really like you don't have any legs. Okay. So, and it's more than just the 3 legs. So we have the data, but now we have to have a computer to crunch the data and come up with a diagnosis. That's our brain, is the computer. So there's a lot more to it. We need other things. So let's take a look. So here's our 3 legs, but you also have expert opinion that you can order to help make your diagnosis. Say I suspect the patient may need a surgery. I'll go refer him to a spine surgeon to get that expert opinion. That can go into making a diagnosis. And then you got to be geeky, right? You got to be up to speed with the medical literature database. And then that will help make your diagnosis. You think, well, it's a spondylolisthesis, and then, I remember that paper said that finding doesn't mean spondylolisthesis. So, and then another important thing is your clinical experience. How long have you been doing this? Because you can get all the perfect data in the world, and sometimes at the end, when the surgeon goes in there to find something, it's not exactly what you thought it was. So it's your clinical experience. And you put all these 6 factors together, and now you've got a pretty darn good idea of what's going on. Okay, so this is everything I said, expert opinion. Do you refer the patient to a neurologist, a spine surgeon, a rheumatologist, oncologist? Okay, add that to the mix. Medical literature, you have to be geeky. Absolutely have to be up to date with the current research. Because algorithms change, treatment algorithms change. So you got to know what's out there and what the literature says is working, right? How do you know if your doc is really into the database or into medical research? A lot of them aren't. So how do you know they're geeky? Well, they publish. Like here's an example. I'm Chiro Geek, right? I love medical research. I love staying right on the cutting front of what's going on out there. Not only do I read it, but I participate. Here's a paper I just published with Dr. Oscar. We did an interesting, you can read it, I'm not going to go into it, but we got it published in a decent journal here, Interdisciplinary Neurosurgery. And so that's just an example. So when you're checking out a spine surgeon, go to PubMed.com and put his name in there and see if he's geeky, see if he's really, really into this. That's the way you find a good surgeon. Then clinical experience. So the more patients you've seen, the better you are. You get at making a diagnosis. I kind of talked about that already. That's why they call it a doctor's practice. Oh, he has a very successful practice. But it is a practice because you're always learning, and the more years and the more patients you see, the better you get. Practice makes close to perfect. Okay, not all patients fit the mold, as I said. So you learn things with your clinical experience. So that's the last ingredient. Put all these together and you can make a diagnosis. Okay, get it? So lay people, never, never, never try to diagnose your own condition. You'll see my warnings on that on all my videos. It's dangerous. You think you got a sprained strain and you end up having cancer. See, you have to be very careful. You have to go to a primary healthcare provider to get a diagnosis. I'm not saying don't look at the research and don't get smart, because you have to advocate for yourself. So I want you to read research, and that's why I make these videos. I want you to know what's supposed to be done when you go see a doctor. All right? But I don't want you to try to make your own diagnosis. Okay, and this is just an example for my coaching. How do you? I can't see you. Most people are overseas or in India or who knows where they are. I talk to people from all over the world. So how can I get an idea of what's going on? Because I can build that three-legged stool quite easily. I can make you answer pre-coaching session questions, which I will do. If you don't answer them, we're going to go over them during the session. It's a kind of a waste of time. You've got to do these before the session. I have you upload your images or stick them in the mail. So we have imaging. There's the other leg. And then examination findings, I have you do some simple testing. I'll put a link to the video below. Maybe I'll pop it up on the screen here when I edit this. But I can build that three-legged stool. And you can also give me medical reports. Maybe you were just examined by a spine surgeon. You can send me that report so I could see I could use his examination findings. I still make you do my own, though. I've learned that a lot of times the PAs who do the examinations kind of shortchange you and don't examine everything as closely as they should. All right? So there's the history. A little more deep about history. I mean, I used to teach this when I taught that class of an algorithm to make sure you get a world-class history. The acronym or the way to remember it is MD's right. Medical medication practically is where M stands for you got to make sure you ask the patient the mechanism of injury. How did this happen? Then the date is for the date of injury. Did it happen yesterday or 5 years ago? All of this makes a difference and affects the diagnosis. And so as for subjective complaints, well, how much pain does the patient say they have? Where is the pain? How are they sleeping? We give them a 1 to 10 scale, which I do on my pre-coaching session questions. A scale 1 to 10, how much pain do you have in your lower back? How much do you have 2 fists above your above your belt line? How much pain do you have in your thigh, your knee, your leg, your foot? So we can build the diagnosis. All this is data. Can you work? That's the W. Are you able to work? If you can't work, that's a pretty darn serious injury. Radiation, does the pain radiate into the lower leg? Does it radiate into the butt, the thigh? Does it radiate into the leg or all the way into the foot? The farther it goes down, usually the better or the worse the problem is. Imaging, what do the imaging results say? And then treatment, have you tried previous treatment? E is for emptying the bowel or bladder. You always ask the patient, are you having hesitancy? You're having any problems with going to number 1 or number 2? And then the medical history, does the patient have blood clotting disorder? Do they have osteoporosis? That'll affect the type of surgeon or type of surgery that can be used. You can't pull on pedicle screws really hard if they have osteoporosis. And then what kind of medication are they taking? For chiropractors, are they on blood thinners? Are they on warfarin, Xarelto, Pradaxa? All the blood thinners. Why do you need to know? Because you're going to bruise the patient when you do adjustments if you don't know this stuff. And then P, the prognosis. Is the patient getting worse? Are they getting better? Are they still the same? That's all part of the computation process. So I've already said this. So I send you pre-coaching session questions. You have to answer. That gives me 1 leg. I got to get your imaging. That gives me a 2nd leg. You can also watch this video on how to upload your MRI. So that gives me the 2nd leg. and the third leg. Now this is where things get a little difficult because I'm not there. I'm thousands of miles away from you probably. So I can't physically examine you, but I can definitely get your medical records. You could send me the spine or the physiatrist's report or the physical therapist or the chiropractor's report. They all know how to do decent neurological examinations. Right? And then I can use that. Or you can, or I'm going to make you do this anyway. You can go over the home examination. So the star of the show in my book is motor examination because reflexes and sensory testing specificity is much lower than motor examination. So this is the key one. That's why I'm going to make you do the motor examination. And you can also see that it's not testing people's motor roots, right? There's L1, L2, L3, L4, L5, S1. These are the main ones that these nerves can get compressed and pain syndromes can occur. You can see how these nerve roots, they go to different muscles and make them work. Some muscles, like adductor magnus, L1 through L4, it has a huge distribution. You do muscle testing on that, maybe it's not going to be so accurate because there's so many different nerves plugging into it. But some of these, there's not quite as many. Like, let's see, where's extensor? There we go. Is that extensor hallucis longus is right here. Notice how that is almost purely L5. So if you blow out your L5 nerve root from an L4 herniated disc, that's going to probably be weak if it's a serious injury. So, but again, lay people, see how difficult this is? It ain't easy to figure this stuff out. All right, here's the video, so go check out this video. I think I put a link down below already. I just published it a couple days ago, so we'll go through all that muscle testing for you. And again, I'm going to show you some stuff, but again, remember this video is, I'm not teaching you to be doctors. I don't want you making a diagnosis for educational purposes only. Never second guess your primary doc on this stuff. But now, this is more on the home testing, how I do it. And you can watch that video too if you want this. This is actually a little deeper than the video if you want to watch this section. Otherwise, we're pretty much done here. But if you want to learn a little bit more, so this is the information that I'll have you do. First of all, if you're wobbly, some people with cervical stenosis, they get really wobbly and they can fall. So make sure there's someone there to watch you and catch you in case you fall. Never do any of these tests where you could fall and hit your head on something hard or sharp, right? Just common sense stuff here. But the S1 nerve root, very commonly injured at L5 disc herniation, paracentral, which is the most common, compresses the S1 nerve root. The S1 nerve root connects to the gastrocnemius, the medial and lateral head, as well as the soleus muscle. Okay, we said this already, S1 nerve root passes behind the L5 disc, therefore paracentral disc herniations at L5 can injure it, and they commonly do. Gives power to the gastrocnemius and soleus muscle. Okay, supplied by S1. S2 supplies it as well. That should be a 2 and S2. But S2 is usually not compressed. There's no more discs that compress S2, so... and we test S1, as you'll see by the video, by doing single leg calf raises. Remember in the video, don't use double leg calf raises. If someone was examining me and they had me do double leg calf raises, I would pass. I could do 10 of them, 20 of them. But if you have me, like you see in the video, when I try to do it with my left leg, I have S1 nerve root damage from that herniation. And then from a scar tissue after the surgery I had. I can't do one of these. So make sure you do it single-legged. L5 nerve root tests extensor hallucis longus muscle. That's the muscle that lifts the big toe off the mat, off the floor. That's really easy. It can be compressed usually by an L4 disc herniation, a paracentral herniation. You could have an L5 far lateral herniation, can also compress this nerve root. It supplies extensor hallucis longus. That's this muscle right here that lifts the big toe. And what else? Extensor digitorum longus is also L5 as well, so the other big toe lifters. Okay, and we'll show you in the video how to do this, but you use a broom handle or yardstick or golf club, and you simply push down on the big toe. and you have a tug of war. I'm pushing with a broomstick, and I'm pulling up as hard as I can with my big toe, and we have a tug of war, and you get an idea of how strong that big toe is, that extender. Then you go test your sciatica one. It better be just as strong. And some patients, they go, oh my God, no one's ever tested that before, and I have no strength. I push down with a broom, and it goes right to the floor like nothing. You got yourself an L5 nerve root injury, most likely. And see, it can be very easily overlooked. L4 nerve root injury causes foot drop, and the patient will catch his foot while walking. So we'll talk about in a second. So that's easy to diagnose. This is not so so easy to diagnose because it's such a kind of a, it's harder to see. You have to do this test to find it. L4, so that's the tibialis anterior muscle right here. Wraps around the back side of the foot here. And this is a dorsiflexor. This cocks your foot. It allows you to walk on your heels. Passes passes behind the disc above the L3 disc. So again, a paracentral herniation of L3 can compress it. Far lateral herniation at L4 can compress it. Both of these can injure. And these nerve roots plug into the tibialis anterior muscle, this guy right here, just like wires. And if the wires are working, the muscle's going to work and you can walk on your heels. If the wires are damaged from a herniation or something else, maybe they don't work that well, and therefore you can't walk on your heels. Okay, there's the classic heel walk. It's usually pretty good at detecting. Unlike the double leg calf raise, this one usually works pretty good. You can also take the old broomstick and push down on the bottom of your feet here and try to dorsiflex your foot like this, and then push down and see tug of war again. See how much force it'll take to push your foot to the floor. This is a strong muscle, not like your big toe muscle. So it takes a lot of force. If you can, you probably won't even be able to do it in a normally function one. Okay, I'm not going to go into, I don't have my coaching clients try to do this. This is just getting too much. Doctors have to do this. You have to physically examine someone for this part. But these are the classic hop and felt hairs, been around forever. It's not perfectly accurate, but it's on boards, and it's still the kind of the book of choice these days. And here's the whole packages. So if you want to test someone's L4 nerve root, you have them, and you see this old school stuff. This is not a great picture. You have them dorsiflex. You don't have them just invert. It's a terrible picture, in fact. Have them walk on their heels. You can test their patellar reflex, right? And that should be working. And forward to the floor, the inside of the leg and the inside of the foot, should have sensation. If you rub your fingers over that, it should feel the same as the other side. I'm not going to get like crazy into this now, but just to show you what is involved in a good neurological examination. L5 is extensor hallucis longus. So Hoppenfeld was published back in the 80s, so this one still holds. They said there's no reflex, but there is some research. This is a pretty accurate test. You have your obturator reflex, it should be your adductor reflex, your adductor magnus. You can tap on that and get an idea. There's no way a layperson can do that, so I didn't even try. But in an examination, you can test on those adductor reflexes for that. And sensation is the top of the foot and the inside of the leg. Okay, S1. S1 is, we don't test like this, so this is back in the 80s they did that, but you do the single leg calf raises. It's much more accurate. And the reflex is Achilles reflex, and that's the outside of the foot. Right, and here's just, this is the neatest study. It's on my website where they, during surgery, right before surgery, they actually numbed the L4 nerve root with lidocaine, the L5 nerve root, and the S1 nerve root, and then they had the patients draw on their leg where the numbness popped up. So for most people, the L4 dermatome, about 75% of people felt it numb right here. And some people felt it numb in a bigger distribution. And then a few, 25 to 50%, found it numb this entire region. So everybody's nerves are different. You see how some people's nerves are really sensitive? Most people's nerves aren't as sensitive. Maybe this patient has struggles with chronic pain more than this patient. No one's ever done a study on that. Okay, get the idea there? And then there's L5, so that's classically the top of the foot, and the outside of the leg. See, there's where most people feel it, about more than 75% feel it there. But a few people feel it all the way down the side of the leg. Same thing for us. One is probably the most accurate of all of them. It's on the side of the foot. Most people feel this one all the way down from the posterior lateral portion of the leg, the posterior lateral portion of the calf, and into the foot. I'll tell you, I have an S1 problem. That's exactly how mine presented. Sweet spots. So 88% of the patients, this is where 4 to the floor comes from. They had L4 numbness on the, and this picture's not the greatest, but that's the medial portion or the inside of the leg. And then 82% had numbness, a patch right over the first metatarsal here in the dorsum of the foot. And then on the side of the foot and the top here, 83% demonstrated like that. So these are kind of dermatomes you can check real quickly to make sure this feels the same as your good leg. All right, see, now maybe you understand how difficult it is to figure out the cause of someone's pain. It's not as easy as you may have thought. So I hope that helped. Again, if you want to talk to me about your images, don't send me just a couple pictures and say, what's the matter? I'd be happy to talk you through my coaching service, which I described at the beginning of the video. But that's the only way I can make a good educated guess about what is causing your pain and then what to do about it. Okay, hope you enjoyed the video. We'll see you in the next one.